Yes, just 1 second. It's
Sure.
almost live streaming. Yes, so good evening, everybody, and welcome. Sorry about the little delay. We were having some technical glitches. Now, over to Nishchita Shetty to invite our uh, speaker for today.
So good evening, everyone. So it gives me a great pleasure to welcome you all for today's session on pediatric rehabilitation. So today we have with us Dr. Priyanka Kuberan, who's a pediatric physiotherapist. So Dr. Priyanka Kuberan holds her master's degree in neurorehabilitation from esteemed Manipal University. And along with that, she brings with her over 13 years of experience in extensively in pediatric physiotherapy. So over the years, she has held significant roles as a staff and consultant physiotherapist at Center for Child Development and Disability, where she's worked for nearly 7 years, and more recently as consultant at Aster CMI Hebal. So along with that, she's also a co-founder of Rehab, a pioneering online multidisciplinary rehabilitation platform, and also founder of Nurture Tale, an initiative that was launched by her in 2017. So, Dr. Priyanka Kuberan employs a comprehensive and evidence informed approach to therapy using integrative techniques which involves neurodevelopmental treatment, reflex inhibition, that DMI, that is dynamic movement intervention, functional training, and most importantly, she gives an intensive parental education to ensure a meaningful motor outcomes in her young clients. Today, she will be addressing us a topic of significant clinical relevance, that is motor developmental patterns in children with cerebral palsy. Her presentation will undoubtedly offer a blend of theoretical understanding and practical insights. So, on behalf of all of us present here, I extend a warm welcome to you, ma'am. And we are truly honored by your presence, and we look forward to the valuable knowledge and perspective that you will be sharing with us. Thank you, ma'am, and we welcome you again.
Thank you so much. Am I audible?
Yes, ma'am, you're audible.
Okay. A small correction. I'm Dr. Priya and not Dr. Priyanka.
Yeah.
Um, so today's topic is motor development patterns in children with cerebral palsy and what to expect in the growing years. Now, we all constantly are exposed to children who have cerebral palsy. That's actually what most pediatric physiotherapists end up seeing. Say maybe out of 10 cases, 8 of them would have cerebral palsy of some variation. And early intervention, what to do in the first few years of therapy. It's extensively documented. Most parents are aware of it. But I realize that there is a lacunae in knowledge base of what the parent has to expect once the child crosses the early intervention stage, and what are the expectations, what are the outcomes, what could be the possible changes in the child's presentation, and then what you are supposed to do to counter them so that the child benefits from all the rehabilitation that the child undergoes. So this is why we planned this topic. So let me start with definition. Cerebral palsy is, of course, self explanatory as a condition. It means it's a group of disorders that affects the development of movement and posture. This is usually caused by a damage to the brain that has occurred either before, during, or post birth. And but once the damage has occurred, so it doesn't progress. So thereby, it is caused by a non-progressive brain injury, and it causes activity limitation. Now, whenever we talk about cerebral palsy, we are always thinking it's a pediatric condition, it's a pediatric disorder, let's work with cerebral palsy children. But of late, researchers who are focusing a lot on quality of life in cerebral palsy are trying to emphasize it, it is not just a pediatric disorder, it's a lifelong disorder. And when I say lifelong, it means that the child is going to, of course, have limitations as a child, and we are going to start intervention. But as they grow, they have to cope with some of the sequelae of their initial presentation. So, by labeling it as a lifelong disorder, we acknowledge the fact that the child is going to have some secondary musculoskeletal issues as the child goes into teenage and then eventually into adulthood. The child is going to have causes for pain, and also as the child goes through the growing years, there could be functional challenges. And by labeling it as a lifelong disorder, we also ensure that we know that the child has to be under rehabilitation of some sorts as the child progresses through the growing years. And even as an adult, rehabilitation does not stop. And the milestones that the child achieves or may not achieve or regress, we need to make sure that there are age appropriate management of all the symptoms. And then we have to ensure that the child eventually then transitions from pediatric rehabilitation to adult rehabilitation in a very informed manner. So this evolution in the definition of cerebral palsy is very important. Now, before we start talking about motor development in cerebral palsy, we need to understand that motor development in typically growing children is usually very predictable. We know what is going to happen in the first year of a baby's life. It is very sequential. So, more or less, the order of development remains the same. One milestone happens and the next milestone happens. Very rarely, we have an occasional overlap or an occasional skip, but more or less, it is very sequential in nature. It is very systematic also. So, every milestone prepares the body over a few weeks to develop into the next milestone. So, thereby, most of the first year, or rather the first 18 months of a baby's life, is extremely systematic in terms of their motor development. It is very purposeful. So, of course, the initial movements might just happen by chance, but eventually the child does all the movements for a purpose, and these purposes compound, and then the child starts progressing from one milestone to the other. So, most of these movements are not in vain, they are often purposeful. They're also adaptive. So if a child learns to roll or crawl on the bed, he's able to eventually do it on the floor. If the child learns to reach or climb onto the parent's body, they eventually climb onto the sofa, they climb onto the bed. So they are able to adapt their learned motor milestones depending on the context. They're also generalized. So when I say generalized, it's not just that the child crawls in one room, doesn't crawl and elsewhere. The child crawls in a well-lit room, does not crawl in a dark room. The child can actually generalize their learned milestones across environmental contexts, basically. They can also combine their skills. So once a child rolls empty handed and figures out that they could reach for a toy, they can hold that toy and roll again. So they are able to combine one milestone and then use it to do other things also. And finally, mostly typically growing children need no intervention. They might need encouragement. They might need a little teaching. They might need a little say positioning sometimes, but mostly there is no intervention required. So that is where, when the child is labeled or diagnosed with cerebral palsy, we know that their development is going to be atypical. And when I say atypical, atypical milestones usually are where the child has a delay, obvious delays, or the child skips certain milestones, or by the time the child comes to you for therapy, there are already some patterns that the child has learned just because of the child's brain injury, and now we are trying to correct it and mold it. So these are like alternate movement patterns that we don't normally see in children who are growing typically. Then again, for the audience members who are parents, they all have retention of primitive reflexes. Now, primitive reflexes are some of the reflexes that are present in the first year of a baby's life. These reflexes have to be present for the child to get into a milestone, but they have to go away or they have to get integrated before the child masters that milestone. So, if these reflexes stay on beyond a certain period of time, they will stop the child from progressing as far as that milestones are concerned. Then you will start seeing asymmetry in cerebral palsy children very early. You will see only one side works or they roll only on one side. There will be early dominance establishment, whereas we don't see dominance emerging in children until much later. So, if you see very early asymmetries, early sidedness, that usually is a sign of atypical motor development. Of course, in toddlers, you see abnormal motor patterns like toe walking, scissoring. Scissoring is where the thighs cross each other. You will see stiffness and you will see floppiness in some kinds of cerebral palsy where the tone is on the lower side. Now, all these patterns that you see on the slide, we normally don't see in children with typical motor development. Now, when it comes to cerebral palsy, before I talk about the growing years, it is very important to establish that there are various kinds of cerebral palsy in terms of the presentation, and your child could be falling under any of these categories, and our management should vary according to that. So, of course, the first subtype, the two subtypes in red are actually spastic cerebral palsy and hypotonic. These are the most common that we normally see in clinics. We also see dyskinetic cerebral palsy, which has this dystonia. A lot of you must be familiar with the terminology. You also see ataxic CP, wherein so these are the four kinds of cerebral palsy based on just tonal variations. Now, when you come to spastic cerebral palsy, it is the most common type. If you see 10 kids in a year, 8 of them will have spasticity. Now, in spasticity, we normally see tightness in muscles. This is a neurological tightness, so it is labeled as spasticity. These tightness of muscles causes a lot of stiffness in joint movement and thereby causes movement limitation. Most of the spastic children have milestone delay and also present with atypical milestones. And spasticity can be presented in different combinations. I will be talking about that in the coming slides, but they can vary in distribution as well as in patterns. And I'll be elaborating that ahead. Most of the spastic children tend to find it difficult to achieve transitional milestones. And again, independent ambulation can be challenging in some of the variations. Again, we'll be elaborating it in the next slides. Now, outcomes in spastic cerebral palsy based on distribution. Now, we generally classify spastic cerebral palsy into based on their distribution. So, we have monoplegic cerebral palsy where only one limb is affected. It can be either the upper limb or the lower limb. Now, if it's an upper limb impairment, it's usually very mild in nature. Even with lower limb, they are able to normally function without much challenges. Then these kids with monoplegic cerebral palsy, they achieve independence very early. They also retain independence. So we will not really have very obvious regression or loss of achieved milestones in monoplegic cerebral palsy children. Functional challenges might be there if the one limb that is involved is the upper limb, and balance issues will be there if the one limb that is involved is the lower limb. Now, in hemiplegic CP, which is again a very common form of CP that we find in clinics, one side is involved. So, one upper limb and one lower limb. Even in these kids, you see mild to moderate impairment. So, there could be very mild presentations, there could be slightly moderate presentations also. But very rarely we have seen hemiplegic kids present with a very severe presentation. They often achieve independence. So, most hemiplegic babies, we are able to convert them to independent walking very early in therapy if aggressive therapy goals are set. They might have some balance issues during walking because one limb is involved, of course. And over a period of time, many of these hemiplegic kids might have functional shortening of the limbs. Basically, because they don't use the limbs to the full range of movement, there could be mild shortening of the limbs. In hemiplegic children, again, because one limb is involved, they might find it challenging to use both their arms for certain activities. But hemiplegic CPs and monoplegic CPs have very good functional prognosis. Most of them are able to achieve functional independence. We are able to integrate them into regular schools because many of them often have good cognition. So, integration is usually not a problem. Hemiplegic CPs can present with mild postural asymmetry because one entire half is usually involved. Now, when it comes to outcomes in CP, when both the legs are involved, we refer to it as diplegic CP. Here we can see moderate to severe impairment. Um, Occasionally, we have seen mild impairments also where just toe walking could be present, but most of the diplegic CP children, they have moderate to severe impairment. Independent walking can be achieved in many of the cases, but this walking would be atypical in nature. So they might be the kids who might show toe walking, scissoring, crouched gait, meaning the child bends and walks. Then these kids might have balance and higher motor milestones difficulty. Most of these kids are functionally independent, but might start having orthopedic complications in the future, and that might cause to lose the functional independence that they gained in the early years. The next category of cerebral palsy based on distribution is quadriplegic CP. Now, quadriplegic CP, of course, falls under a very severe impairment category. Independent walking is usually very difficult to achieve. Not that it's not possible, but it's hard to achieve. Many children in quadriplegic category with severe milestone issues can also struggle with achieving sitting and other floor transitions, and many of them as they approach their teenage and adulthood might be requiring assistive devices or mobility aids. So functionally, of course, they end up being very dependent. Now, these were the four categories of spastic cerebral palsy based on involvement of the limbs. Now, we have two very obvious patterns of cerebral palsy. They are based on the patterns of movement. So, we have the flexor dominant spasticity, basically where all the muscles that bend the joints, they get affected. So, in the upper limb, you will have bending of the elbow, of the wrist, of the fingers, of the shoulders. You will have turning of the forearm. So, thereby, your arm function is limited. In the lower limbs, you will have bending at the hip, you will have bending at the knee. Many times there will be crisscrossing at the hip. That is what we refer as hip adduction. And the ankle can go into plantar flexion, that is toe weight bearing. So, because of flexor dominance, like all the bending muscles being tight, as far as upper limb uh, function is concerned, these children often reach, but their reach is very limited. They cannot do far reaches. They grab things, but they find it difficult to release things. They find it very difficult to weight bear on their hands. And with lower limb involvement, these are the kids again who do the toe walking, scissoring, crouched gait. And most of the kids who fall under the flexor category of cerebral palsy, they are the ones who end up having contractures and joint deformity as they progress into the adulthood. Because many of these kids and teenagers, when they achieve mobility also, most of their joint range of motion is in the middle range, so they don't really go to the extremes, and those ranges become tighter, and over a period of time, because of non-use, contractures can develop. Sorry about that. Then the next pattern of cerebral palsy, just like we had flexor, we have extensor spasticity. This is actually very rare. Here we have increased tone in muscles that actually straighten your joints. And so basically, children might present with extreme extension at the wrist, or the fingers will be open all the time, does not close, and the hip and knee don't bend, so they walk, they might achieve walking, but the walking will be very stiff and robotic. These kids might actually struggle to maintain sitting for a very long time. And somehow we can get them to supported standing and some form of atypical walking. But of course, they will have balance issues. They will have problems in sudden turning. They will have problems with some functional skills like carrying and walking. And of course, there is a very high risk of fall in this category. But this is a very less common presentation that we see in clinics. So spasticity has been classified in all these categories. We also have three important forms of cerebral palsy. We have the dystonia, that is the dystonic CP. In dystonia, it is extremely challenging as a condition, and that's also because the child experiences extreme fluctuations in muscle tone. The child can be extremely tight, and then suddenly there can be a drop of tone. Even the tightness can keep varying, and there can be a lot of uncontrolled involuntary movements of the limbs. The child might try to take something in the hand and bend because he could not control that aspect of his posture. So dystonia happens to be very difficult to manage purely because there are a lot of variables that the child presents with. The child, of course, all the milestones are delayed, and their postures, stable postures, they find it very difficult to maintain because they're constantly moving. Of course, functional skills using the hands can be very challenging, and it is very hard for us to produce consistent results because position, emotion, reflexes, all of them start influencing the child's presentation, and it takes us much longer to achieve even the simplest of the milestones. The next category that we have is ataxic CP. Ataxic CP is again very less presentation wise. We don't really see a lot of ataxic CP. Maybe in 2 years, I might get one ataxic CP in my clinic. Here you see a lot of shaking. The child has a lot of trunk instability. They will have a lot of balance issues. They will have a lot of coordination issues. We are able to get them to somehow walk because the base tone problem is not so severe, but then the cost of walking is very high. So when I say cost of walking, I mean the energy cost. They have to really struggle very hard to get to a point of stability and then take a step. So ataxic CP is another kind of cerebral palsy. And of course, we have the hypotonic CP. Now, everybody talks about spasticity in cerebral palsy, but certain forms of hypotonia also fall under cerebral palsy. Some forms of brain damage do cause very gross hypotonia. So here you have very low muscle tone. The babies are very floppy. Head control becomes very delayed. In fact, that usually ends up being the first sign of concern. All the milestones are delayed here because of muscle weakness and a lot of instability. You may also see excessive joint movement here. So, thereby, the child does not get great feedback and depends on very wide base in terms of sitting, standing, and their movements might be very slow and they might fatigue faster also. Now, having described all the forms of cerebral palsy, I have to make a very important point here. No matter at what age we get the baby in our hands for interventions, most of our interventions are actually competing against physical growth of the child. When you look at growth spurts in normally developing children, right, in the first year of a baby's life, the baby grows about 10 inches to a feet, right? And their body weight triples by the time they are 1 year old. And then in the early childhood, you have smaller growth spurts that keep happening. The growth continues to happen. Maybe it's not so rapid, but it can be influenced because of hormonal influence. There could be genetics, there could be nutritional influence, there could also be activity. So if you have tall parents, there you might have faster growth spurts in the younger age group. If your activity levels are high, you may have more growth spurts in the younger age group, but predominantly the major growth spurts that happen for girls between the ages of 8 and 13, and for boys between the age of 10 and 15. And thereafter, during this period, the child, girls can grow up to 2 to 3 inches every year, and boys can grow up to 4 to 6 inches every year. Now, in growth, as far as growth is concerned in cerebral palsy, because there is constant tension, especially in spasticity, because there's constant increase in tone of the muscle, many of these kids can have stunted growth. They can also have slower growth, but um, their body proportions, like some of them, because their lower limbs are involved, the upper limb can actually develop, the upper half of the body can actually develop normally, and the lower half of the body ends up not developing. So they can look disproportionate. Um, if the cerebral palsy child has feeding issues, then they can also present in the other extreme where their body weight is low and their BMI is also on the lower side. So, growth patterns in cerebral palsy are highly influenced by skeletal deformities and muscular contractures, and we will learn a little more about them in the following slides. Now, as the child grows, and especially in cerebral palsy, as a child grows, we need to understand that whatever progress they make as far as their motor milestones are concerned, they are not able to always compete with the rapid bone growth. So I often tell parents that what we achieve as a milestone is very specific for them in terms of their bone length, their height, their weight. So a slightly substantial increase in height and weight can actually lead to a poor outcome, and we could see a small reduction in what we had achieved. So this actually puzzles parents a lot, because we sometimes we achieve walking at around 3, 3.5, and then at 5 we start seeing the walking patterns are changing a little bit because the child has gained a little height and weight. So this is very important to remember that every growth spurt can cause a mild to moderate regression in the child's motor ability. Of course, this happens during the early years also, but it is very common in the puberty age. So between 9 and 16, you can actually see a low regression in terms of their motor milestones. Now, there are some models based on some studies that were done to understand the Percy children across their lifetime. These were longitudinal studies done across 10 to 15 years. Some of them say that the child achieves the best presentation, their maximum motor ability by the age of 5, and then after it's plateauing, and then as they grow, it starts declining. There are some studies that say that children achieve their.
Dr. Priya, I think your phone has got disconnected. We cannot hear you.
I'm so sorry. I think I got locked out of the presentation. Dr. Gauri,
We can hear you. You're breaking a little.
okay. I will restart my slide. So sorry about that. Can you see the slide?
Yes,
Okay, I'm so sorry about that.
no problem.
So as the child reaches these ages of plateauing and declining motor milestones, one of the factors that happens is that there is a change in the child's bony alignment and joint alignment. So bones can start showing signs of low density. Bones can start having abnormal angles, especially the thigh bone. You can have joint alignment issues, very common at the hip. Thereafter the knee, and also around the ankle. And because now there is a slow regression of motor milestones, the end range muscle contractures can become very obvious. Now, the way contractures are different from tightness is that tightness can be manually released. Like you can get the child to the end range. The child might defend it a little bit, but then eventually will yield and you are able to get to full range of movement. But muscle contractures usually are unyielding, and then in the future might need surgical intervention. And as they start growing and their body weight increases and height increases, the effort that they were putting for movement that was relatively easier maybe in the younger age starts becoming difficult. So when they start voicing out fatigue and tiredness, they might genuinely mean it, because naturally the muscles have to now work against a larger load, a longer load, and that can cause increased physical effort for movement. And this phase is when there could be a temporary or sometimes a permanent regression of some of the motor skills that we have achieved. which can also lead to increased fatigue. And here is also when a lot of cerebral start complaining of pain, because now it's a combination of muscle pain, joint pain, and pain was never a factor before this. And now with Mota milestone regression, you can actually start uh, experiencing your child report pain. There could also be, so physical growth is a very important aspect of regression. We often see kids across, say, many years, and we often see that their best performance and presentation is often till the age of 5 or 6, and thereafter therapy sessions become limited. We could probably do 10 exercises in a session and before that, and then suddenly we are able to do just 5, and the child does not cooperate so much, and because they are not able to put in the same level of effort, and we start seeing this in clinics as well. So of course physical growth is a big cause of motor regression. We also have some medical causes for motor regression, so they could be chronic pain, of course. So child does learn to tolerate some levels of pain, but then if pain becomes persistent, then they start not liking to move around. Many kids, especially the ambulant kids with a lot of deformities, can be at risk for hip dislocation that can cause a motor regression. Many cerebral palsy kids have comorbidities like seizures and an epilepsy disorder. So sometimes an increased epileptic activity in the brain can also cause a motor regression. Nutritional deficiencies, maybe they're not eating as well as what their body needs in the growing years, and that can lead to a motor regression. As they gain height and weight and the effort goes up, they also have difficulty breathing, many of them, not all of them, and that can make them not very willing to participate in day to day activities, and that can cause a motor regression. And of course, over a period of time, the child is tired all the time, just because day to day, the movements that the child has to do day to day is just extremely fatiguing. So, chronic fatigue can also lead to a obvious motor regression. Now, prevention and management. Of course, I always believe that early intervention is the best prevention. The faster we are able to get the kids who can get to walking, it's always going to give the child a major time advantage. If a child has started walking at 2 and a half, and then has had like 3 to 4 years of continuous walking before their first growth spurt starts interfering, they would have had a lot more practice, and sometimes they can adapt to that a little faster. So of course early intervention is the best prevention, but irrespective, it's very important to have ongoing therapy. Sometimes you have to empower parents with, even when you scale down therapy, which a lot of therapists do once a child achieves independent walking. It's very important to empower parents with some of the important exercises that the child can have as a part of their daily routine. And then you need to have periodic reviews with your physiotherapist, because they are the ones who also will understand that this exercise is probably not so effective, so let's try and add something else. There is no harm in trying alternate approach from a different therapist if that's available in your city. That is also the age where you can really try a lot of things to keep the child's body mobile. Sometimes in the growing age, if you are not able to support the child very well, and it's very important that the child goes to school and participates with other children, and say the foot is going for a deformity, there is no harm in prescribing a good orthotic for the child, or supporting their spine with brace so that they can sit through the day in school without any difficulty. So if there is regression, you have to also learn to support the child with adequate measures. Then of course you need to have periodic reviews with your neurologist, not only to sometimes get certain medications that can help you with management of your symptoms, especially spasticity medications. You can always try other medications with them. Sometimes you also have to taper some of the medicines to get some better outcomes. So it's always good to have at least once in 6 month reviews with your neurologist. It's good to have periodic reviews with your orthopedic surgeon also, because as you cross the age of 9, 10, that is when a lot of surgeons start exploring the possibility of doing surgical interventions on these children. So you could probably have an option to do a muscle lengthening. You could have some bony operations, joint corrections, tendon transfers, those kind of surgeries. If the child can cope with the post surgery rehabilitation, this is all often the age where a lot of surgical interventions are explored by orthopedic surgeons. So periodic reviews with your surgeon can also be useful. Of course, exercise has to become a part of the child's lifestyle. Therapy should not be something that he does specially. It should just be something that the child does daily, because their consistent retention of motor milestone is dependent on how active they are. There is no second thoughts about it. So, maintaining an active lifestyle will always help you counter whatever regression the child may experience as the child grows. Um, it is also a good time to start discussing with your physiotherapist whether getting the child used to a mobility aid like a walking stick or crutches or walkers, or sometimes for severe disability, a wheelchair, if that is going to be a child's life, maybe this is the good time to explore such options. Now, there are some studies that have been done that in the growing years, some of the strategies that really helps the child in countering any form of motor regression is strength training. Strength and progressive resistance training under the supervision of your therapist can actually help in increasing muscle strength, and they can also sometimes help in maintaining muscle length. So thereby we can prevent some of the disabling consequences of cerebral palsy. Aerobic exercises like walking, running, swimming, cycling. If the child is wheelchair bound, just moving the wheelchair around, dancing if the child can is functionally independent, they improve your cardiovascular health, that is your heart and your lungs, and also help you in weight management. We need these children to stay in a very healthy weight zone, thereby they don't become a burden on their own muscles. And of course, cardiovascular health is very important because these kids and these teenagers, they are not as active as other teenagers of their age group. So you might have to support them with aerobic exercise. Flexibility and range of motion exercises like yoga can actually had a lot of benefits to the child once they are in that age where they start understanding their bodies. Balance and coordination and sensory exercises can also help in just maintaining the child's motor abilities. So, as far as the dosage is concerned, they say a customized 60 minutes of moderate to vigorous activity, which is supervised and which is consistent. So, at least 6 days a week, the child has to have these exercises done. And of course, with safety consideration. So, no vigorous movements, no extreme stretching, everything within the ability of the child without causing him any harm. Now, no growing year conversation can continue without us talking about the GMFCS classification system. Now, around the age of 6 or 7, we start thinking on the terms of this classification. So, this is an internationally established classification that classifies children into 5 levels. The first 2 levels are actually the independent levels. The first level, the child walks without any limitations. In the second level, the child walks with limitations. So when I say limitations, I mean the child might need to hold the wall or the railing or your hand. The third level is usually handheld mobility devices like walking stick, walker, crutches. The fourth level is where the child has good upper limb and trunk and so can probably maneuver their wheelchair on their own. And the fifth is where the child has very severe disability and has to be transported in a wheelchair. So these are the 5 major categories of functional classification of motor systems. And they say that when we start categorizing children at the age of 6, under this, we are able to sometimes predict what the child will do at the age of 12. So usually, if a child coming for therapy is under the level 1 or 2, then we know that the child will retain some form of mobility by the age of 12 and beyond. At level 3 and 4, there is a good chance that the child might need assistance as the child progresses into adulthood. And of course, 5 is a very severe impairment stage. So it is always important that periodically you classify your child according to this system and also explore options with your therapist. So again, based on the studies done using the GMFCS, we know that GMFCS categories 3, 4, and 5, which are the more severe categories, here the motor capacity is usually plateau by the age of 6 to 8 years, and thereafter it starts declining. Um, in non-ambulant children, that is GMFCS level 4 and 5, there are high likelihood of developing contractures or hip deformities and dislocation, and also postural issues like scoliosis. We also have GMFCS level 2 and 1. Here we know that they are usually hemiplegics or mild diplegic CPs or monoplegic CPs. These kids actually can maintain a stable gross motor function, might experience occasional regression, but usually correctable. So, of course, this is research. So most of the research is about majority of the children, which they all fall under one side of the bell curve. Now, there are always going to be outliers. So we know that although this is the norm, not all children with cerebral palsy will follow the same developmental path. Although GMFCS tells us that this child may or may not be independent in the future, many factors can influence a child's outcomes based on the kind of therapy they are doing, the kind of access to resources, the kind of functional development the child has. So maybe a child with better cognition and emotion might actually perform better in those growing years and might be able to cope with the challenges of motor regression. Also, access to early diagnosis and intervention and very vigorous goal setting in the early years of therapy can make a very important difference in the child's functional independence. In current age, of course, there are a lot of wearable technology that's being developed, which might be more and more accessible in the coming decade, like pressure sensors, accelerometers, exoskeletons, basically wearable robots, fitness trackers, and all of them can be cleverly integrated in a child's day to day, just so that there is a lot of self awareness about the child's condition. And irrespective of all of this, we do know that, especially in kids with very high levels of disability, every small improvement that they make has to be appreciated and celebrated. And that is important because that becomes an incentive for them to do better and try and push themselves from certain levels of dependency. Now, cerebral palsy is a subject on its own. There are so many variables. There are so many elements here. But some of the key takeaways, especially for the growing years, for parents, is that progress is always possible. Children with CP will they if we are able to keep them consistently in therapy, do exercises at home, provide them with all forms of assistance, they can keep learning new skills. So it is never that they stagnate, but we should be able to stop, reassess, and then provide them with newer realistic goals based on where they are in their stage of development. Regression is of course inevitable. The child is actually fighting natural growth, and there is a good chance that milestones can go back, but with good informed interventions you can actually control the pace of regression. Also, it's very important to understand that it is not, our goal in therapy is never to get to normalcy. It is to get to the best independent version of the child that we can cultivate. So, also, we need to develop a multidisciplinary team for the child so that all forms of regression can be addressed. For the sake of the talk, I limited my discussion to gross motor. But as the trunk and the lower limb start getting affected, some upper limb issues can also develop. And that's a topic by itself. But if there are any questions regarding the same, I will address them in the question answer session. um, it is also important for parents to always remember that you are raising a child with cerebral palsy, and then your aim is to ensure they transition into adulthood with maximum independence that their bodies can allow. So, our aim should always be to achieve that. For clinicians and other interventionists who might be a part of the audience today, there has to be a lot of emphasis on early intervention. We have to be very aggressive in our goal setting, especially in the early years. And we have to look for any orange flags, red flags, and try to correct them very vigorously in the early years, of course. But once we cross the early years, it is very important to stop, reassess, discuss realistic functional goals with the parents, and counsel them and handhold them into making these adjustments for their children. Parental education, of course, it's non-negotiable. Parents have to be a very important element of the child's rehabilitation. The more informed and involved they are, the more your outcomes transfer into the child's day to day. And of course, teamwork is the most important aspect of countering any motor regression in cerebral palsy children, especially in the growing years. Thank you so much for your time. I'm really sorry for all the technical challenges we had, but I hope I was able to cover a few key things. And if there are any questions or discussions, I'll be willing to take them in.
Hello, everyone. Am I audible?
Yes,
Yes.
Rupali, you're audible. You can
Okay.
take it further.
Hello, everyone. My name is Rupali. So now we have reached to our question answer section of the session. So if you have any queries, please feel free to ask, or you can comment on the chat box. So let's start with the first question. Let's address the question, which is how do and why CP occurs in a baby?
Okay. Cerebral palsy can happen due to many reasons. Usually, the reasons can happen before birth, during pregnancy, the end stages of pregnancy. They can happen during birth. During birth, the child can have breathing issues, birth asphyxia, a prolonged stay in the NICU with several complications can lead to cerebral palsy. Sometimes infections post birth, like encephalitis, can also cause cerebral palsy. Many times we categorize certain incidences, like if the child has epilepsy, that can lead to cerebral palsy. So there are a lot of reasons for cerebral palsy, of course. Um, and but irrespective of the cause, more or less, their presentation remains within the domain of today's discussion. So, but this damage happens once. It's a one-time event. The brain learns to reorganize around that damage, but we need to keep managing the symptoms of cerebral palsy as the child progresses.
Thank you, ma'am. Let's move on to the next question, which is can you discuss why regression is happening and can you explain it again?
Like I said, when a cerebral palsy child achieves a certain milestone, their milestone achievement is very specific. So I'm just going to give you a very simple example. Say the child is around 9 kgs, the child is 18 months, and he's a mildly, say, diplegic cerebral palsy, where both his legs are tight. So he's learned to walk. There is a little bit of toe walking, there is a little bit of, say, scissoring, but is able to keep himself up and walk around. Now the child is around 9 kgs. Now imagine the child enters the third year of its life, and there is a sudden increase in appetite, because now the child has started finding mobility. The child starts eating well. There could be a gain in weight. So from 9 kgs, the child moves on to say 10 and a half, 11. Now for a child, this particular change in their body composition, weight, height, can appear as a new challenge. And the muscles actually struggle to adjust to these minor changes in height and weight, purely because the skill that the muscle gains is very specific to that particular position of the child. So we often see that minor changes in the body height and weight can also lead to regression, and it is something that you anticipate and you prepare for. So that is why the child has to constantly stay active, not just random exercises, but certain targeted exercises based on the child's presentation. So regression happens because the child is often competing against a growing body, and the muscle tightness doesn't allow the child to quickly adapt its changes. So that is why regression happens. So that is, of course, the most obvious cause of regression, but there are other causes also. Regression can happen because of, say, a sudden increase in seizure activity. Regression can happen because of an illness sometimes. Regression can happen because of nutritional deficiencies. Regression can happen because of a lot of other factors also, sudden loss of activity. Sometimes a style child starts school, and the sudden emphasis is on academics, so they are not moving around as much. And then they come for a review 6 months later, and we think the child is a little worse off than before. So all of these factors can cause regression. So it's just that the muscles have to be constantly exercised to their best possible range so that they can counter any regression growth spurt can cause.
Thank you, ma'am.
Mhm.
Moving on to the next question is how to counsel the parents who are unaware of CP.
Um, I think you have to start day one. I feel it's very important to explain to the parent who comes into your clinic with with the child that this is not just a mild delay. This is not like a delay the child will outgrow. It is very important to understand and make them understand rather that the control of the brain over the muscles is compromised here. So they normally think, oh, tightness is there, we will massage a little bit. It will get better. So it's very important to differentiate between orthopedic tightness and neurological tightness first of all. So the way you counsel a parent is to start day one. You have to start giving them comparisons. It's important to make them understand that milestones have to be achieved a certain way. And if the child is not achieving it, and there are some incorrect movements which you normally don't see in typically growing children, that is where you have to highlight that this child is growing differently, is attempting things differently, or not attempting things at all. So I often believe in parent education. I think irrespective of language barrier, say even sometimes we have parents who come from rural areas, we should try our level best to highlight how this child's development is different from a typically growing child, and then basically start from there. And then it's important to slowly ease them into the diagnosis, and then start teaching them everything that you can in terms of home program also apart from the theory you do. And then after 6 7 months of showing them results in your clinic as well as uh, making them participate at home, the combination works. And most of the times by the year end, they are able to understand the severity and the importance of the diagnosis and what they are expected to do as the child progresses also.
We got few questions from the registrants before also. Let's
Okay.
address them.
Sure.
First one is how to reinforce patience while CP child is under long rehabilitation treatment. And
Uh,
added to that question is, can CP children lead normal life?
um, Normalcy is something that we don't really always aim for, especially if the severity is very high. We normally like to define or answer this question by saying that you take the child to as close to normalcy as possible. So, whatever the child's body can allow. But having said that, I have seen kids with, say, who are in that GMFCS 1, 2, and 3 levels, right? I have seen that with a lot of vigorous work, a wide variety of therapies, a lot of involvement of parents, I have seen a lot of change happening irrespective of the severity. So I feel it's very important to counsel them that normalcy is 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 a very unnatural expectation. We have to try and push the child to the best version of the child in terms of independence. And in the earlier, like the lesser impairment categories, right, where we have one limb or one side or two limbs, there actually the child can lead a very near normal life. But of course, there also you might have to support the child's growing years with orthotics or good support or postural support sometimes, and have periodic reviews, just like I mentioned in the talk, because that will ensure that you are able to counter any regression that can happen in the growing years. And I think, as far as patience is concerned, therapy is a long drawn process. And after the early intervention phase is done and you achieve a good milestone in the clinic, it is very important to have a very diligent home program. The child has to follow like a timetable, and at least 6 days a week, you do a wide variety of exercises with the child and make exercising at home a part of the child's lifestyle. Then they slowly start changing. And I have seen kids, as they approach their teenage, they are a lot more, they are aware and they want to do it, they want to get better. So that's how you probably deal with chasing normalcy and also patience for therapy in the child.
Thank you, ma'am.
Hmm.
There is one more question, which is how and what to identify the difficulties of motor developmental problems affecting academic learning, and what is the right age to intervene to help children with such issues?
Yeah, this is a great question. Actually, a lot of kids with mild to moderate disability are quite capable of attending mainstream school with some supports if required. Now, academically, the child will struggle if, say, the posture the child maintains in school is a challenge. So imagine the child has weak extension muscles. Basically, the back muscles are not very strong, but the child is expected to sit on a high desk and focus on the blackboard and uh, write. And this can be very challenging for the child. And so, maintaining the posture as well as focusing on academics can prove to be very difficult for the child. So, I feel when you are attempting to accommodate these children to normalcy, especially in an academic setup, say in a school or like you have to try and ease the postural demands so that learning does not get affected. So I often tell parents that if for school you need to strap the child to the chair so that he can maintain a straight posture, does not have to maintain his posture, then he might be able to have more energy to focus on what is being taught. Similarly, many children who have the flexor type of cerebral palsy, they can struggle with a normal desk and bench arrangement for writing. But the same child, if put on a low bench where you accommodate their flexion, they might be able to write very well. So I think it's a case to case basis. But the moment you start integrating these children for academics, it's very important to understand what are the postures in which the child is able to participate well, and see if in a school setup you are able to recreate or at least provide supports so that the child does not have to do therapy during school. So the child can be well supported during schooling and other academic pursuits, because the demand of posture maintenance can be extremely taxing, and that can compromise with the child's natural ability to learn. So the child actually might be very bright, but because he's constantly fidgeting and twitching and they're not able to find a good posture, and their muscles are fatiguing, that could be one of the reasons they are struggling academically. So I think each child, where you're trying to pursue something academically, you have to assess them and try to find out which is the best possible position where the child can give their best for any academical learning.
Thank you, ma'am. For the viewers, any other queries you have or any thoughts you would like to share, please feel free to do so.
I think there's one question on YouTube. Can you provide information with respect to hypotonic CP? It's a very vague question.
So I think hypotonia itself is uh, we sometimes try to not call them cerebral palsy. Also, it's because with mild to moderate hypotonia, we often get very good outcomes, and they are the ones actually we discharge very quickly from therapy and just do probably once in a year follow ups. But in hypotonic CP, there are three major elements. One is these kids have poor trunk control mostly. So these are the kids who we often find they are the ones who will be lying down and writing, who like to lie down on the floor and play. If given a choice between a stool and a sofa, they will choose the sofa. So they are the ones who want to conserve energy in most of their positions and functions. So I feel hypotonia, but at the same time, you also have the severe version of hypotonia where they are very floppy, head control is delayed, trunk control is severely delayed, and their outcomes can be very challenging because it takes years sometimes to get very limited improvement. So, for the mild to moderate hypotonic categories, I often tell that irrespective of therapy, once your therapy stage is done, ensure the child leads a very active lifestyle. You put them in endurance building sports like cycling, swimming, which actually builds their muscle tone and make it a part of their lifestyle. So that way, the truncal weakness, which is sometimes there, but the child just overcomes it because of activity and just being very agile, it can be countered. So that is for the mild and moderate kinds. The severe kinds, of course, you have to explore a lot of supports for posture, for sitting. Sometimes even a collar is required to enable some form of say composed head control so that other things can be taught. So hypotonia, yes, very rarely discussed, but it can, because it's such a big spectrum. The mild to moderate ones end up having great functional life. With severe ones, yes, it's a case to case basis. We need to provide them with as much support as possible.
So now I think Hamshi has a question. You can unmute and ask Hamshi.
Thank you, ma'am. Thank you, Dr. Priya. That was a really nice talk.
Yes.
I have a question. I know there's a lot of discussion around primitive reflex integration and its
Mhm.
effectiveness. So,
Mm.
what's your perspective on the value of those interventions, especially when the research findings seem to be like very mixed?
I wouldn't spend a lot of time doing reflex inhibition exclusively. I think it really depends on how much it is interfering with the child's progress. So, just to give you an example, I have a very severe dystonic child with um, very strong corticovisual impairment. Child has very low cognition. And this child is in persistent state of ATNR, and we ATNR is one of the reflexes. I don't know if you're a therapist, so I'm just clarifying.
Yes, ma'am.
This particular child, we couldn't really do a lot of active NDT with this child because the child was so reactive. And because of his persistent presence in that state, we had to address the reflex first, get him to neutral, and spend a lot of time doing that. And of course, reflex inhibition can be seen as a slightly passive approach, but you have to typically educate parents and delegate a lot of the inhibiting uh, maneuvers to them. So ensure that you teach them what is to be done and see whether over a period of time you're able to slowly incorporate those maneuvers into your active NDT or any other therapies that you do. Because if the child continues to stay in that state, it can really impede function. So you might not really make a lot of progress. But having said that, mild to moderate presentations of reflexes need not be so aggressively pursued. I think if you pursue active physiotherapy, get the child to do a lot of functional movements and improve the motor control, basically, if you improve the hierarchy of motor control, reflexes sort of start getting integrated or managed almost on their own. It's in the severe categories, especially in dystonia, we see a lot of persistent reflexes, and I feel like it is something that you might have to spend a little extra clinical time addressing it. But it is something you can't put it in the back of your brain. It's very important to constantly use it in your active therapy because they do give you good results if you know, but it's a case to case basis.
Yes, yes, ma'am. That makes
Mm.
sense.
Yes.
Thank you so much. Yeah.
Yeah.
So anybody else would like to unmute and ask, or Anything more? I think one of the aspects again to highlight is about the orthotics and support whenever, wherever necessary, it can.
Yes, yes,
Like
yes.
as you have mentioned, I think if it takes away, it gives them the support and takes away the fatigue of just maintaining their
Mm,
posture and things, I
mm.
think it help a lot.
Actually, when I was deciding to like make this topic as a part of today's discussion, it actually came from a case discussion, and I would just like to talk about it. I had discharged her in 2017 or 16, I think, and she's close to 10 or 11 years now. We came for a review, and this is me seeing her after almost, say, 8 or 9 years, and she's prepubescent, so going to achieve puberty anytime now. And the child I had discharged, or rather, I didn't actually discharge. Mostly the tendency is that the child achieves walking. Many parents tend to discontinue therapy. So I think that is what had happened. And this child came back after 8 or 9 years and still walking, but walking and the knees are bent, the spine is bent, her movements don't seem positive, like it doesn't seem confident at all, and all elements of like a flexor pattern cerebral palsy. And this is not the child I had discharged, I would say. So I think what has happened in the last 8 to 9 years, also with COVID and all of that, they were happy that they got walking, but they didn't want to push her very much because she was a preterm baby, and COVID put a small hurdle in their activity levels, and so all of this and not having worked on her at all has led to a very grossly deformed kid, although she has retained walking. But this walking is going to soon become very painful for her. And I realized that when we don't prepare parents for all these phases of regression, they will let it slide without understanding, to be honest. And then what we get at that teenage is not the most efficient version that the child could have been. So I feel it's very important to constantly remind parents that it's it's a race, right? You know, your body is really challenged, and you are just racing against growth and so many other factors that start playing a role in the child's life as the child grows. So not keeping regression in your mind could be a big failing. So I think I felt like it was very important that we highlight this. Although it feels a little negative, but to be honest, it prepares you. And it also, if you know that this might happen, say, you might research more about supports, you might research more about, say, for a severe child, you might research more about the next powered wheelchair, or say a good quality walker, or like you if you know this is going to happen, you will be better prepared. So I felt like this was a very important topic that nobody really talks about, so that's one of the reasons I wanted to present this.
Thank you very much for that.
Mm. Although it was so much of a technical challenge, I'm so sorry about that.
No, I think
See
we
how challenged we are.
as people working with children and their difficulties, we know that we have developed to find ways to work around our
Sure,
challenges.
sure, sure. Sure.
So not to worry. So
Mm.
so Varsha, can we now close the session if nobody has any more questions?
Sure. So, on behalf of Brainchild Trust, I would like to give my heartfelt gratitude to Dr. Priya Kuberan for enlightening us with an insightful talk on motor development patterns in children with cerebral palsy. Thank you for sparing your time, ma'am. Her expertise has significantly enhanced our understanding and knowledge regarding typical and atypical motor development, subtypes of cerebral palsy, growth spurts in the typical children, and how the motor regression happens in cerebral palsy, how to prevent and manage, or the strategies to improve the motor outcomes in the growing years. So, I would also like to thank Brainchild Trust for organizing this webinar, enlightening webinar. And last but not the least, I extend my sincere appreciation to all the participants for their valuable time and cooperation and their patience. Thank you all once again for making this webinar a success.